All right, good afternoon, everyone, and welcome to Neurology Grand Rounds. So we're pleased to have our first resident-led CPC of the 2016-2017 Grand Rounds series. And our resident presenting the case is Matt Preston, who's one of our fine N3 residents. So Matt is from St. Louis, and he did most of his education in Missouri, going to the University of Missouri as an undergraduate, where he majored in biology. He went to medical school at St. Louis University before coming to Seattle in June 2013 for his internship, and then neurology residency. And Matt has always been one of the most effective and knowledgeable residents that we have. It's been a long time since I've been able to easily teach Matt anything, so he's been a great resident, and we're looking forward to hearing him present his case to Dr. Max Ma. And most of us know Max from his time as a resident here and now as an acting assistant professor, but I'll just review his background briefly. He is from California. He went to college at UC Berkeley, where he studied molecular and cellular biology with an emphasis in neuroscience. He went to Weill Cornell College for medical school before coming to University of Washington for internship and neurology residency. After he finished his neurology residency, he left for San Diego to complete a neuromuscular fellowship or a clinical neurophysiology fellowship. And we were really happy to have him come back and join the team at the VA and the University of Washington again. And I'll just say, many of you don't know this, but Max has set up a Tuesday conference, which has been very effective and shown his aptitude as a clinician educator, where we're covering all aspects of neuromuscular disease. And it's been great for the residents and the faculty. It's been kind of a mini neuromuscular fellowship. So thanks to Max. If I miss any neuromuscular questions on my research, I'm going to be ashamed of myself. So thanks, guys, for doing this. So Matt, take it away.
Max claims that he shoots his jump shot with 60% accuracy. At least.
That's pretty good. Yeah. Where the how do I kill these slides? I always need some help here. I'll let you take care of that. Yeah, just the overhead lights. Yeah.
Thank you, everyone. Is my mic working? Sounds like it is. So, all right, thanks. So this is the Clinical Pathologic Conference. So I have Dr. Ma, who's going to be helping answer some of the questions as we go through a case. So just to start off with, I don't have any disclosures. There's a patient that I saw in a clinic. His BH. He's an 18-year-old gentleman. He's referred to the neuromuscular clinic for long-standing weakness, and that's actually worsened in the last year. He doesn't have any sensory complaints, and this is kind of just what we hear when he's coming into the clinic. So, Dr. Ma, kind of right off the bat, when we have a patient just coming in with that kind of a complaint, or anything, right off the bat, you know you're going to be wanting to look for as far as your history?
Well, I mean, I think the age gives you some.
We're going to have to get a microphone.
Dr. Mara will text me and say, I can't hear now.
Well, this is not the typical VA sort of demographic, but I think the age can certainly help you to rule out common forms of many conditions in the neuromuscular realm, and you know, the time course. Certainly, 1 year is sort of subacute to chronic, and so that will also help you to rule out some of the more acute forms of neuromuscular weakness, such as, you know, Guillain-Barré and the like, and then no sensory loss. Obviously, that rules out a lot of nerve diseases, a lot of plexus and root diseases, and so you know, I think begin to start to tailor your list a little bit from the moment you get that chief complaint.
Great. So he gives us a lot more history, as you might imagine. So he says, well, his dad actually tells him that he's always been a very scrawny guy. So he's never been, big in sports, but he's always kind of noticed weakness in his shoulders and kind of his lower extremities on both sides. The course has kind of been progressive. He's been falling a lot, but in the last year, what he's noticed is that he used to be able to run like 2.5 miles at about 10 minutes a mile, which is a pretty decent pace for him. But then in the last year or so, now he can't even run even a 1/4 mile at a time. He gets pretty short of breath when he runs and just very fatigued. And then for as long as he remembers too, he's had this hypermobile joints where he can basically dislocate his shoulders kind of at will and put them back. And that's kind of just been an ongoing thing that hasn't really been evaluated for.
So I guess I'll say just a couple things. So this seems to go back further when you dig into it, and that opens up more things under differential. Certainly metabolic conditions when people have trouble with physical activity, but no, some may or may not have sort of static weakness at rest. And when somebody, I think, staying with the exercise, you can get a hint if it's a metabolic problem of what part of the metabolic pathway is defective, or whether they have sort of early weakness and symptoms versus late. Certainly dystrophies would be high on your list as well, given sort of this time course. And a lot of it, I haven't seen a lot of sort of mitochondrial diseases, but the ones I have seen, they tend to be on the skinnier side.
Great. He has a little bit more history, kind of just a birth history. He was born full term. Development was normal. He made all of his milestones. Didn't have any complications early in life. He felt also that he thinks his calves are pretty large because he's overall pretty scrawny guy, but his calves in particular seem large to him. And because of this difficulty with exercise before, he's been actually diagnosed with exercise-induced asthma, and so he's tried inhalers in the past, and that really didn't help him at all. And so that was another interesting component of his. This is kind of what he told us as far as his history of present illness. So are there any points in particular that you would think would be helpful as far as further evaluating his history?
Since we're sort of gravitating toward muscle diseases at this point, and given that this is CPC and you're going to be showing slides, I feel pretty confident that we're in the right sort of zip code at least. The other points when I think about muscle diseases, besides what we talked about in terms of time course, age of onset, also there are certain other physical exam characteristics or also on history that could help to narrow the differential. For example, weakness of facial muscles can bring up things like FSHD, myotonic dystrophy, really any distinguishing facial features. Family history can give you a sense of autosomal dominant versus recessive or X-linked types of diseases. If you are talking about some of the metabolic things, ophthalmoplegia, so does he complain of double vision? And the thing that we can't forget is neuromuscular junction diseases can also cause muscle weakness, so I'd want to know whether or not there's fluctuations in his symptoms throughout the day, and whether or not environmental factors like temperature can affect his symptoms. The last thing I'd like to know is whether he has any cognitive problems, because some of these systemic diseases can involve the cerebrum, and that can also help us to develop a better differential.
So as far as one of your questions was fluctuations, he tells us that really he notices when he gets active, he tries to be active, he gets fatigued pretty easily, but otherwise he doesn't know any other reason for him to just have very wide fluctuations. And things have been kind of progressive, kind of slowly over time with that worsening in the last year. He does give us a little bit more is his past medical history, kind of that shortness of breath that we talked about, and then just a couple of injuries from falls before. Family history, he doesn't have a whole lot. There's a maternal great-grandfather, though, required 2 canes to walk, and they don't really know what the kind of details on that really were, but just that he had dislocated hips at some point. And also he had some folks on his mother's side have pretty hypermobile joints as well, so they can kind of get dislocated joints, and that's something they've noticed, but they've never had any kind of diagnosis or any other medical problems that they're aware of. As far as social history, so that cognitive aspect that you mentioned, he graduated high school, but he actually did so a semester late. He pretty much got D's throughout school, and there was some concern that attendance was a problem. Apparently he moved around a little bit with his mom, but they didn't have any learning disability. It was diagnosed, and so it was really kind of unclear why he had that kind of difficulty. So,
Does he have siblings?
what's that?
Does he
Siblings?
have siblings?
Yeah, he does have 2 siblings, and they're both perfectly healthy. Like, they can play sports and do all sorts of stuff. Yep.
Have they had pulmonary function tests so we understand the nature of his pulmonary restriction? And is he limited in any other way by what he terms weakness besides running distance?
So he has not had any. Oh, sorry. The question was: has the patient had any pulmonary function testing, and is he limited in any other way from his weakness? So for his pulmonary function testing, no, he has not actually had any pulmonary function testing at this point. And as far as limitation, otherwise he notices that he has difficulty with like stairs and some getting around, but otherwise he doesn't notice. Well, actually, I should rephrase. He does have a little bit of difficulty with speaking. Occasionally, if he speaks for a very long time, he notices he gets a little dysarthric. That's the only other limitation that he brings.
How about using his hands, keyboard skills in particular,
He,
thumbs?
yeah, he can use his hands. There's not a problem with that.
You probably covered this a little bit, but a specific question about family history would be that any sudden cardiac death. People know, they remember that. They might not remember weakness, but everyone knows.
Right. So they didn't have any evidence of a sudden cardiac death in the family history.
Do you have any contractures, any reports, or difficulty physically moving or going around the joint?
Great. So Dr. Weiss asked if there's any contractures or difficulty moving his joints, and there are not. There's no contractures.
Getting back to the cardiac issue, I'm just wondering if his exercise-induced asthma could actually be cardiac and there's an associated cardiomyopathy.
Right. That's a very good question too. That question is his exercise intolerance potentially due to a cardiomyopathy rather than asthma or some respiratory condition, and that's certainly possible. He hasn't had any kind of workup for a cardiac condition at this point.
Any bowel or bladder symptoms?
This question is any bowel or bladder symptoms, and he doesn't complain of any. So, any other questions? Okay, we'll go on to the neurologic exam, and Dr. You already mentioned a few of the things you look for: the ophthalmoplegia, facial weakness, that sort of thing. So we'll go on. This is a neurologic exam. His general exam was pretty unremarkable. His mental status was normal to our short screening test. His cranial nerves are normal, except for he does have some weak eye closure bilaterally, and his smile is pretty weak, so he doesn't give a big full smile on both sides, but he's able to puff out his cheeks and do that. His tongue seems normal. He can stick it out, it protrudes midline, no problems otherwise. His motor exam, though, is also pretty remarkable. He has decreased bulk, and it's a pectoralis muscle area. He has some decreased bulk in the shoulder deltoid area, and then otherwise his calves seem a little bit increased in bulk compared to the rest of his muscles. His strength is, he has some evidence of some proximal weakness only, so deltoids are 4 to 5 biceps, hip flexion, but the remainder of his strength really was full. And there is scapular weaning present when you test for that.
And if I can just
Yep.
pause you for a second. One thing that I do want to remind residents about examining anybody with weakness is is sort of appreciating just observation. I think before you kind of jump in and start to move them around and confrontationally test them, is just take a moment and ask yourself, does this person look normal? From the moment you get them from the waiting room and watching them walk, watching them sit down, get up, you can glean a lot of information just simply by observing that person, and also is just to remove the clothes. For a lot of conditions, they have very classic appearing bodies, and when you see it, so that could almost be diagnostic sometimes.
You mentioned that he was always scrawny, but I didn't hear anything about his childhood development as far as learning to stand and walk and run.
Yeah. So the question was about his development, and that was completely normal. His tone was normal as a baby. He developed appropriately, hit his milestones. He wasn't really ever into sports, so he didn't really get out and run around with the top of his class, but he kind of did, was able to be active and participate.
Height and weight.
Height and weight. Good question. So I didn't put that in here. He is on the lower end of the BMI. His height, I think, I want to say it was like up 5'10" or something around there.
So 2 things. One, were his hands checked for myotonia?
Yes, he did not have myotonia.
And he said, in his history, he said his calves were big. Were his calves big?
Yes.
How big?
So they were disproportionately big. We didn't have a measurement for him in his calves. But
noticeably.
Yeah, they were noticeable. No, I did not palpate the calves to see if they were soft.
Did he have any neck flexion weakness, flexion extension?
No, he didn't at that point.
He was able to sort of rise from a chair or get up from the floor.
So he did have some difficulty rising up from a chair. So what he did was when he tried to stand up, he would kind of have to swing way forward and then get up off the chair, and then he'd kind of push himself up a little bit with his hands to stand up. And then he could walk. He kind of tended to walk on his toes a little bit, but he was able to get around independently.
Could he step up onto the step?
He had a lot of difficulty standing up. We didn't have him step on a step, but he would have had difficulty, I think, trying to get on a step.
How far did you have him walk? Did you get him to the point of being weak?
So he showed some weakness kind of right off the bat. We didn't have him walk too far, just in the...
So how did that look? That means his gait wasn't normal.
What's that?
You haven't actually described his gait.
Right, so his gait, he kind of, when he got up out of the chair, he kind of walked on his toes, and so he was leaning forward. He did have relatively short strides.
Did his hips look stable as he walked? Or
So
did
he did have some waddling of his hips. Yeah.
So is his tongue big?
His tongue didn't appear big. Okay. So other things on exam, his sensation exam was normal. His reflexes were normal as well.
Did you watch him take off his shirt?
Did I watch him? I did not. No. Okay. So, kind of going with that exam, do you have any further evidence of what you would do to localize the symptoms, or what kind of things you would do at this point to try to help determine what's going on?
Yeah, so I think going back, we've sort of, if this is sort of a painless weakness, and if we're talking about the pattern, it seems to be pretty symmetric, it seems to be proximal, and it doesn't seem to wax and wane or have much fluctuation. So I think we're in the realm of muscle disease, and then if you think about the major categories, I think this is less likely to be an inflammatory type of muscle disease, given that tends to hit people more in the 5th, 6th decade, muscular dystrophies, I think, is pretty high on the differential at this point, given that he's had this for so long, we talk about metabolic types of conditions like McArdle's disease or mitochondrial conditions. Some of those characteristics fit and others don't. I do wonder about some of the other questions that other folks have asked. I'm really glad that Dr. Gosby is here, given the age of this patient. He did not warn me about this. So yeah, that's what I have to say at this point.
As far as the muscular dystrophies, you mentioned that. Is there anything in particular within that class?
Yeah, well, there's some hints of facial weakness that you pointed out, and there's, I think that the two, as far as talking about common things being common, myotonic dystrophy is one. You certainly look for a family history in that, but you can have the type 1 myotonic dystrophy, which has a pretty classic presentation. And then type 2 tends to be a lot milder and present later in life. But big calves, I'm not sure if I associate that with myotonic. He does have some features on exam of FSHD, with the way that you describe the pectoralis atrophy. I'd want to take a look at his chest. They have this pretty characteristic horizontal axillary crease, whereas normal people it's vertical. So that could be sort of a pathognomonic thing for those guys. I'd want to ask him, can you whistle? Can you drink out of a straw? But otherwise, they also just have a pretty typical proximal sort of shoulder girdle type of weakness.
Okay, good. So this is kind of a little bit of a list I came up with. So muscular dystrophy, I thought, is also very likely. So Becker's was one particular, gastroscapulofemoral, limb girdle, muscle dystrophy, inflammatory, inclusion body, Pompe is another metabolic glycogen storage, spinal muscular atrophy, Emery-Dreifuss are all potential kind of muscle diseases that can.
Right. So obviously, when you talk about big calves, everybody's thinking Duchenne's,
Yeah.
Becker's.
Right.
So that's high.
Okay. Going on, I shouldn't have showed you that yet. So as far as a lab workup, we didn't really talk about that, but what would you have wanted to do as far as...
I would predict the CK to be 6,000.
Okay, that's very prescient. Any other workup you want to do at this point?
Yeah, somebody suggested pulmonary function tests, so I want to know what his FVC is, what his MIPS are. I think, as far as getting down to analysis of the muscle, you're talking about EMG, muscle biopsy, and things like that. You'd probably want to get an EKG, make sure his heart is functioning fine. Certain muscle diseases cause, a cardiomyopathy. For example, Duchenne's and others cause more conduction issues like in myotonic dystrophy. So you probably want to get like an echo and an EKG. And I think just sort of general labs, make sure his liver is working okay. You might, if he does have any cognitive issues, you might get a brain MRI, and any leukoencephalopathy might point to certain conditions.
Great. So he got some of those things, but not all of them. So the lab kind of workup, he got the CK, which was elevated. Otherwise, his lab workup was pretty unremarkable. His head LFTs are normal. He had a mildly positive ANA at 1 to 80, so it was unclear what to make of that. His ESR had been normal. And then he didn't really want to get an EMG, so that actually wasn't done for him. But he did want to go ahead with getting a biopsy. And so we did that. He had a biopsy in his left thigh. Do you think that would have been your next step? You mentioned that. Was that something you would have done kind of at this point?
I would have convinced him to get an EMG.
Yeah.
Matt, what did you say the CK was?
The CK was over 6,000.
No, muscle biopsy is not the next thing.
Okay.
Absolutely not.
Okay.
Genetic testing.
Genetic testing. So what testing would folks do other than the biopsy at this point?
FSH and Duchenne muscular dystrophy lab test.
Great.
The CK is not high.
Becker's. He doesn't have Duchenne. He's got either FSH or Becker.
I vote for, because of the scaffolding, I vote for sarcoglycan.
So Dr. Weiss says sarcoglycan.
Do you have a panel? Can this panel?
Yeah, we do now.
Alright.
Yeah, it's also free.
So the opinion is that genetic testing would have probably been the next step for fragile scapulohumeral dystrophy vectors, and we would also look for limb girdle muscle dystrophy.
You're going to have to take control here, Matt. I can see that the audience.
The mod.
Okay.
Oh, those tests are massive.
Acid maltase too. Okay. Well, he had the biopsy before we got all those things. So he actually had this one before he actually came to see us. So this was actually done kind of when they referred him over to us. So here is an example of his muscle biopsy. This isn't his. This was done a while back, so I didn't have the actual slides for him. But this is a pretty good example of kind of what he has. Do you notice anything in this H&E slide of his thigh?
Yeah, it doesn't look normal. Some salient features, I would say, typically you have polygonal shaped fibers that are relatively similar in size and without a lot of space in between them. Here, the architecture is abnormal. You have fiber size variation, where you have bigger fibers and smaller fibers. A lot of these fibers have nuclei that are not on the periphery and in the center, and that's a sign that the fiber is trying to regenerate. On the left there, maybe that little triangular one, that might be sort of a necrotic type of fiber. And then the one on the bottom left, I'm not sure if that is a sign of, a split fiber, a fiber that's...
This one right here is harder to see on the screen,
Yeah.
but there's this one too.
Right. There might be a little bit of an increase in immune cells, but really not that dramatic. That's what I would say. I don't know if you guys have anything else, Dr. Weiss.
Yeah.
Okay.
So your interpretation fits with what the pathologist thought as well. But do you have a sense of what you kind of classify this type of a H&E stain as? Like what kind of a process is going on that cause these changes?
So, like I said, it doesn't seem to be terribly inflammatory, and because of the amount of architecture change, I guess I would lean toward a dystrophic type of muscle.
Yeah. So that's also what the pathologist thought. It said it wasn't real definitive for a dystrophy, but there is certainly some signs of it. And so findings were, just like you mentioned, the increased centralized nuclei, there's muscle size, fiber variation, necrotic fibers, regenerating fibers, splitting fibers. Myopathic findings, but dystrophy was a concern. So here I just labeled some of the things that we talked about. This one right here is one of the splitting fibers. It's harder to see on this actual smaller picture here. And so there's some notable negatives, though. You mentioned some of these. So they didn't have inflammatory cells infiltrate, so like a inflammatory process. There wasn't any endomysial fibrosis, no inclusion bodies, no normal microvasculature, no ragged red fibers. So that helps you kind of narrow down your thoughts too.
So Max, what do you think this biopsy makes a differential a lot less likely to be
So the question was, what does this biopsy do as far as narrowing down your differential?
Do you expect to see more inflammation in Duchenne's?
Duchenne's more than, and a lot more fibrosis, probably in vectors.
Yeah.
I would think, although I guess it's conceivable.
You see more what looks like inflammation in FSH.
That too, and then same thing with some of the limb girdles, like how where you get scapular wing and limb girdle distributes like 2A, copy not. And then ragged red fibers, that doesn't actually exclude a minor chondropathy, but it makes it a lot less. It sort of decreases the likelihood.
So Dr. Weiss mentioned that the lack of ragged red fibers is an indication that maybe this is less likely to be a mitochondrial myopathy.
Good.
I realize this is, the biopsy that you showed is not his biopsy.
Right.
It's
Right.
stock I don't see any, like you said, there's no endomysial fibrosis, but there's also no indication that there was fatty replacement. So
That's correct.
this is very inconsistent with the kind of muscular dystrophy we see in pediatrics. And I'm more inclined to feel that this description, realizing that we're not looking at the biopsy that he actually had, is more consistent with congenital myopathy, like centronuclear myopathy, or we need to do other immunohistochemistry to see if there might be abnormalities in the way that the fibers are proportioned versus type 1 versus type 2, etc.
Right. So the point was brought up that there could be some other differential diagnoses, and immunochemical staining could be helpful for differentiating what's going on here. Any in particular stains? We have some that were actually done next by our lab here.
I think if you're looking for ragged red fibers, you probably want to see a Gomori
Yeah.
trichron.
Yeah, so that was done. There's also these other stains here that were done, and just kind of review what they found on our patient. So oil red O stains, so there's no abnormal lipid presence, there wasn't fatty replacement of the muscle, and ADH staining was normal. Periodic acid shift was also normal, didn't show any abnormal glycogen storage, and ATPase stain showed kind of predominance of type 1 fibers, but there was no fiber type grouping, and it was pretty unremarkable otherwise.
Which would be an indication of denervation and reinnervation.
Right. And so there was some immunohistochemistry that was done here, and these are the results of those. So sarcoglycans were tested, a couple different types, dysferlin, dystrophin C terminus and N terminus, rods, and G sarcoglycan, and those were all pretty unremarkable. Does that help you at all?
Do you know if they tested or stained for the alpha dystroglycan and beta dystroglycan?
They did not. This is all that they stained for. But we did ask for from some further evaluations that was done, sent to a different lab, and I have some further results. So you asked for alpha dystroglycan and what was else? Beta and beta dystroglycan. So I actually do have those results here. We talked about that. So here's kind of another panel that was done at another facility. And so this was dystrophin. There was alpha dystroglycan, beta dystroglycan, caveolin, dystrophin rods, and then some similar kind of ones that we had before. But they showed a couple of abnormalities here that we didn't see before. So alpha dystroglycan was reduced, as was dystrophin. And so that was something that we hadn't recognized before. And here's an example of, again, the picture of what we can see in here. So this is alpha dystroglycan here. This is an example of normal and abnormal decreased. So in this patient, this is again not his, but there were it was a pretty mild decrease in all of these ones. It wasn't a real marked change. So does that help narrow down?
Well, I mean, a lack of dystrophin would then validate the theory that this is in the Duchenne-Becker's realm. And I'll let Dr. Weiss kind of take over from there.
I think.
So the antibody to dystrophin was to the.
It's 203.
Maybe it was.
So alpha dystroglycan, there are two different forms, the IH6 and VIA4, and then the dystrophin aminoaxon 7 to 8 and 9 to 12.
So just the dystroglycan, I would think about maybe glucogen-related proteinopathy, because that protein is heavily. The alpha dystroglycan is staining, which is glycosylation.
Mm-hmm.
And in the absence of that protein, which there's no antibody directly at KRP test for essentially indirectly testing for that particular protein.
So Dr. Weiss comments that it's a fucotin-related protein that could show this kind of pattern with decreased alpha
I'm not sure
dystroglycan.
about the dystrophin.
So that's also kind of what the pathologist had thought too. There was some myopathic features, not definitively dystrophic. Then since there was these abnormalities, so they considered dystroglycanopathies and also dystrophinopathies. And so the dystrophinopathies would be the Becker's and Duchenne's, and then the dystroglycanopathies would be like limb-girdle muscle dystrophies.
But there isn't actually, I think there's only been one reported family with a mutation in dystroglycan gene itself. So the testing actually specifically speaks to glycosylation, paired glycosylation of other proteins that are important for stabilizing muscle memory, in particular FK.
So
I thought that dystrophin stains that were done here were normal.
yeah, they were. So it was pretty mild when they called it over there. So that's why they were not real definitive as far as calling something on this final test. But they did think that it was abnormal, that we called normal when we had that same testing here.
It's not incredibly elevated. Probably wouldn't. That wouldn't be the thing that I would worry about. It's the like seems like the thing.
Okay. So Dr. Wang says that the dystrophinopathy seems less likely given what we know about the history in the CKs. Would think that the dystroglycanopathy would be more likely. Okay. So what would you do at this point then? Testing.
So I just had a question on that point because they said greater than 6,000.
Yeah.
So is that the max in that lab? I mean,
So it was in the 6,000 range. It was less than 7,000.
I know.
Yeah,
So
it was like 6,000 to 7,000. I didn't have the actual number in
I
our
see,
initial.
I see. Okay.
So you know, Leo and I are thinking about limb-girdle dystrophy type 2I because those patients do get big calves. They can, yes, it's not as, I think we're not sure about the scapular winging, but certainly we have scapular winging with some limb-girdles. The big calves are often typical. And the impaired staining of alpha dystroglycans is that possibility.
So Dr. Weiss and Dr. Wang mentioned that this could be limb-girdle muscle dystrophy 2I, and that would be consistent with the calf hypertrophy, and the scapular winging is less clearly associated with that diagnosis. So for next testing, it sounds like you would send out some more genetic testing for this one.
We actually do it for free in the MBA clinic.
What does the I mean by the I?
So the I is just, so all the limb-girdle dystrophies are designated by whether they're either autosomal dominant, in which case it's 1, limb-girdle muscular dystrophy type 1, and then 2 would be recessive, and then they're alphabetized after that. So A, B, C, so it's 1A, B, C, D, E. So 2I is just that letter of the alphabet that once that gene was characterized with the protein, characterized they added, that came in as a limb-girdle dystrophy type 2I.
So that's 9 different genes for the type 2.
No,
There's more than that.
more than that. But it doesn't stop at I.
Yeah.
What does it go down? What does it go down to now?
So there's up to 20.
It's like Z.
It's
It's
well into the alphabet.
Yeah, that's not Z, but it's going to be Z pretty soon.
But I would say that if you have someone who has facial weakness, scapular winging, pectoralis weakness, you have to keep FSH on the list.
So the point was that given that there's facial weakness, scapular winging, and kind of this pattern, that vasculoscapulohumeral dystrophy would be something you would still keep on the list and want to evaluate for as well. So you'd include that in the next round of testing. Yes?
Did I miss it, or did we get results of PFTs or?
Oh, PFTs were done and they were normal.
Echo?
Echo was not done at this point. He came in before this result, but it was normal on the first scan that we did. Okay. Going on. So genetic testing does show this, what Dr. Weiss and Wang had mentioned with the mutation in the fucotin-related protein, which is the dystrophy 2I. So that is what we found in this patient. So I just wanted to go on a little bit to talk about kind of what the limb-girdle muscular dystrophies are like. Any comments about that before I move on?
How often do you think that it really occurs and we don't recognize it?
So that's a good question. I'll get into that a little bit. The question was how often does this happen that we don't recognize that it's a limb-girdle muscle dystrophy? I have some numbers as far as prevalence I'll get into a little bit, but I think that it is under-recognized, certainly. But limb-girdle muscular dystrophy is primarily affecting the pelvic kind of shoulder muscles. There's overlap with multiple different disorders, and so the things that we had been talking about before with Becker's, especially given the calf hypertrophy, myotonic dystrophy type 2, Pompe's disease, FSHD, and so we have to consider those in our workup. So many subtypes. Actually 27 different ones I found on a review article, so I don't think it goes down to Z because there's divided into A1 and 2. Type 1 is autosomal dominant and type 2 is recessive. So remember in our patient, he had a great-grandfather that had some weakness, pelvic dislocations, and walks with a cane, with 2 canes. And so, that kind of skipping generations would be a pattern you might expect for a recessive trait. Cardiomyopathy in limb-girdle muscle dystrophies is pretty common. And there's quite a wide range of severities as you might expect with the variety of the genetic causes of limb-girdle muscle dystrophies. So as a group, it's the 4th most common genetic muscular condition, so like 1 in 20,000 overall. So it happens, but FSHD is certainly much more common as an example. Most common, there's a variety of different proteins that can be affected, and I'll have a slide on what some of them look like in the muscle. 2A is the most common, and 2B is the next most common after that. And basically, one of the questions was asked, how do these guys figure out what they're going to name them? And basically, they were named 1 and 2 based on the inheritance, and then otherwise they're just in order if they were found, they got an extra letter added on. So this is an example of all the intracellular components that are involved in limb-girdle muscle dystrophies. And so as you can see, all of these on here are limb-girdle muscle dystrophies, and basically just there's quite a variety of different targets that can cause this symptom. So right here is dystrophin, that would be like Becker's and Duchenne would be affecting here. Alpha dystroglycan is up here, and that's where the FKRP is affected, so that's like glycosylation. All right, and there's a sarcoglycans over here. And here's just a partial list of some of the limb-girdle muscle dystrophies, and I'm not going to go through these in detail, but just kind of they do have their own clinical phenotypes that are different, and you can somewhat differentiate which type you have based on the clinical phenotype, but there is still a lot of overlap, and you're not going to diagnose which subtype it is just based on the clinical history alone.
So can you say what test did you send off on him?
Oh, so yeah. So the testing for his, it was testing for, it was a panel that tested for the fugatin-related protein, because that was the dystroglycanopathies, because that's what we were concerned of.
Was it a limb-girdle muscular dystrophy?
Yeah, exactly.
But you didn't send off
FSH.
Becker's.
Right.
You didn't send off for FSH.
Becker's, I think, actually, that was sent to, FSH was not sent. Going on here, this is just a higher depth here, caveolin, so this is the one that's affected in 2A, and again, dystroglycans up here. Beta dystroglycans, alpha dystroglycans, which is the one that's affected here. And so limb-girdle muscular dystrophy 2I, so there's quite a wide range of severity, and there's actually a few different clinical phenotypes that can happen with the 2I. I'll get into that in a little bit, but muscle hypertrophy is one of the characteristics of 2I that's not present in a lot of the other ones, and that's what can you pick up on to consider. But actually, interestingly, with it was brought up multiple times about cardiomyopathy here, and these patients can get pretty significant cardiomyopathy, and it's pretty frequent, and actually can be quite out of proportion to the skeletal muscle involvement too, and early on in the course, and that goes for the respiratory involvement too. And so the sub 2I is actually more common in Northern Europe than it is here, but 20 to 40% of limb-girdle muscle dystrophies there versus 10 to 15 here, and it's 1 in 54,000 in the Norwegian population of this subtype. And the onset ages can be very varied as well, 2 to 50, and that depends on which what mutations you have, because it's an autosomal recessive inheritance pattern in the fukutin-related protein, so FKRP, and this is a protein that's expressed in all tissues, but mostly in the skeletal and cardiac muscle. 2/3 of these patients will have a homozygous C826C to A mutation, and that is a more mild form if you have that one, and if you have a different mutation in addition to into this one, you will have a much more severe phenotype and have earlier onset of your symptoms. So other phenotypes, so these wouldn't be necessarily limb-girdle muscle dystrophies, but they're also related to mutations in this gene. You can have a congenital muscular dystrophy that's just a more severe, earlier onset kind of phenotype. You can have just recurrent myoglobinuria that's related to this. You can have asymptomatic hyper-CK, high elevations in CK. You can have isolated dilated cardiomyopathy as the only symptom as well. And so clinical presentation kind of is what we found in our patient. Proximal leg weakness is prominently, calf hypertrophy, lumbar lordosis, scapular winging is a feature of this, and macroglossia can be seen, and cardiac and respiratory dysfunction. And they often can walk into their 4th decade, and cognitive dysfunction can actually be present because alpha-dystroglycans are actually involved in brain development too, but it's not a common feature of this one. Going on into the diagnostic workup, so some things to consider in this one in particular. CK, often 10 times normal. Muscle biopsy will show what we saw, the dystrophic pattern and decreased alpha-dystroglycan. Electrophysiology can be used to rule out other diseases as we have been talking about earlier. And our patient did not have one of these. MRIs, interestingly, have been studied in this disease, and there was a study that they looked at MRIs of the thigh, and they compared it at baseline and 12 months later, and they showed that there was actual progression that they were able to measure, and that was something they could use to just note the progression of disease, and it's more sensitive than the clinical findings that they were finding on exam. And the genetic testing, obviously, which we mentioned. So genetic testing is a first-line kind of option. We had that discussion before we talked about the biopsy, and I didn't find like every case series I had about this type of muscular dystrophy, they've all had biopsies before they really kind of diagnosed with this condition. But there's multiple papers that brought up doing genetic testing as a kind of a first-line thing instead of going for a biopsy first in this patient. Has anybody had any experience as far as, is that something you guys would jump to doing a whole exome sequencing or something like that before?
But I don't think I would go to a whole exome sequencing. I would do a panel, and the reason why I would do it is we got 30 free kits sitting in our office. You do a panel of like 28 genes at Emory for free.
So I'd like to make a point about that. I don't know what your experience has been with that free Emory panel, but it's taken between 9 and 12 months for Emory to turn that around.
Wow. So you have this, I don't know who you're doing it through. Ours for us is 4 to 5 months.
Gosh, that's lickety split, isn't it?
So for those on the internet, the discussion was about you can do these patterns for limb-girdle muscle dystrophy, and there's a panel that can be sent out, and there's varying return times, either 9 months or 4 or 5 months, depending on, I guess, who's asking.
But you could do it
Full
commercially.
term or premature?
You could do it commercially, and it would not cost more than doing a muscle biopsy.
That's true. I would agree with that.
So
I totally agree that you can. We've been going down the road of doing genetic testing lately. We have these free kits before we do muscle biopsy. I will do an EMG. I'll tell you one reason why I'll do an EMG. If there's anybody who has just a limb-girdle presentation, you don't do an EMG. You won't know if they have myotonic dystrophy. And myotonic dystrophy type 2 will look a lot like a limb-girdle dystrophy presentation, and they often don't have clinical myotonia.
So Dr. Weiss brings up the point that he would always do an EMG in these patients in order to look for myotonic dystrophy, because that's something you won't necessarily find clinically, but you will find on the EMG study.
So
But also, go ahead.
for somebody who doesn't have access to the kits, like what would you send commercially?
You can do the limb-girdle
Just
panel.
limb-girdle, not anything more.
You can either do a shotgun, do a whole bunch of things, or you can just do the limb-girdle that you think you've got. That comes back negative, and you can do a couple more.
So I would say this, for those of you who want to kind of hedge your bets, who'd like to get a little information about these patients, the Jane Foundation has this really, which is an organization that sponsors research for limb-girdle dystrophy 2B specifically, dysferlinopathy. The Jane Foundation has this really nice algorithm that you can go through that will kind of focus on specific diseases based on sort of Bayesian statistics as you enter data. It will give you this information of the likelihood of specific disorders being more probable than not. I'm happy to give you that website information. Anybody's interested.
So are these hypermobility or connective tissue related symptoms common in this, and would those be seen in any of the other disorders we spoke about?
It's a very good point. So Dr. Ransom asked what about this hypermobility that he's had in his joints. Is that actually related to this disease? And as far as I can tell, no, it's not. And we're not really sure why he has hypermobility. It could be some separate thing going on, but it's not been described, I don't think.
Is alpha-dystroglycan the only protein that's glycosylated by FKRP, or does it glycosylate other extracellular proteins?
That is a very good question. I don't know the answer to that. The question was if there are other proteins that are glycosylated by this FKRP.
Let me also say, in terms of this, what test would you do?
Mm-hmm.
And he had both a biopsy and genetic testing, and one of them was diagnostic.
That's true. So the point was that you had both genetic testing and a biopsy, and only one of them was actually diagnostic. So it seems like the genetic testing is a good.
If you did a panel, because otherwise
Yeah.
you wouldn't know.
Yeah. So one of the studies I had in here, the one here, this does want to suggest that using genetic testing as a first line, and they said in all their cases when they diagnosed it, they wanted a biopsy or some other clinical evidence to kind of make sense of the genetic panel rather than just blindly going with the genetic testing. But not all cases they suggested there had to be a biopsy.
I think the take-home point is if you want to maintain your friendship with Dr. Bird, then don't do a muscle biopsy first.
Doesn't it also mean that his great-grandfather was irrelevant?
It's great.
Grandfather had something else.
Why you would
Because the disease is homozygous.
right?
His
Yeah.
great-grandfather may have been a carrier, but
Yeah.
that is very symptomatic.
So the question is his grandfather a red herring? I guess it's possible.
And he was a grandfather.
Okay,
Right.
great grandmother.
He
Yeah.
would have had a really probably late onset form of this illness, which seems a little out of keeping with
Right.
the description you provided.
Yeah, so
How long do these patients live?
So that's a really good question. Akaksha asked, how long do these patients live? And I actually tried to find that out, and I couldn't find anything that really had a very extensive natural history on these folks. The only thing I really found was about you can do some MRI testing just to follow up, but I do know that folks walk well into their fourth decade and later, so they have pretty significant cardiomyopathy and shortness of breath, so I suspect their life expectancy isn't normal, but I don't know what the average is.
Has anybody treated them with steroids?
So Dr. Swanson asked if patients have been treated with steroids, and there are case reports of these folks having been treated with steroids, and there has been some documentation of them improving. In one case in particular, biopsy showed some increased inflammatory cells, and that patient did improve, but there's other patients that didn't have biopsy with the inflammatory cells that also improved with immunotherapies, IVIG or steroids, but there's not been any kind of there was one randomized control study that actually did not show a significant improvement with steroids.
Has this young man had any investigation into whether he has cognitive developmental delay? He did poorly in school. He raised the possibility that there can be cognitive delay in these patients. Do we know?
Yeah. So the question is, in this patient, did he have any cognitive testing so we can see where his cognitive abilities are? And he actually did not. He's a patient that kind of came and went every few years and didn't really keep very close follow-up.
So, Matt, very nice presentation. Max, thanks for your input. My question to this group of muscle experts that are flanking us, skeletal muscle, pretty much expresses the same genome. And there's a genetic defect here, different genetic defects that produce different patterns of disease. Why is that?
So I will defer to some of our neuromuscular experts around here. The question was why is there, correct me if I'm wrong, Dr. Ransom, but why are there different phenotypes associated with these mutations that are
all expressed in skeletal muscle?
All expressed in the same skeletal muscle, yeah.
What's the answer to that question?
I'm sure it's a good question.
So, why are there so many
Why
phenotypes?
are there different patterns of dystrophy when you've got skeletal muscle that's expressing the same genome?
That's a great question. I don't think none of us know the answer to that. Why? That also speaks to inflammatory disorders of muscle. Why is polymyositis does it involve inflammation of axial muscles, whereas inclusion body myositis selectively targets deep finger flexors and the quadriceps. And in the quadriceps, it spares the rectus femoris very commonly. Why are some of that? I don't understand either. So there's a lot we need to learn about how these different muscle fibers are targeted. It's going to get exposed to how we can eventually treat these diseases, I think.
I feel like the other side of the coin is that they do share a lot of similarities in their clinical presentation. When you talk about limb-girdle muscular dystrophies and inflammatory myopathies, the rule generally is a proximal pattern of weakness. And so I think there's sort of two ways of looking at the same problem.
It may be fair, but why not find out your feet muscles? Why not, eye muscles? There are many that don't seem to do anything to those, but yet they're all skeletal muscle with exactly the same genetic expression.
I wonder if as you lose muscle strength diffusely, it's just clinically more apparent that the weakness is proximal, but that they do have some level of weakness everywhere.
So it may also, maybe it has something to do with some diseases just have a predilection more for the fast twitch, fatigue sensitive, big type 2 fibers, which are more proximal to the hip flexors and biceps, as opposed to extraocular muscles, which aren't. But I think that we really don't know. Because you're absolutely right, Bruce. There's some diseases that have predilection for certain muscles, and it doesn't make sense to me why that is. It's the same. They're all skeletal muscles.
So might it not be telling us that all skeletal muscles are not the same?
Yeah, I think that is what it's telling us.
Well, yeah.
Are all astrocytes the same?
I think it depends a little on who you talk to.
Right.
There can be some variability.
All neurons are not the same.
Yeah, but at least in the case of, it's for sure not true, but they express all kinds of different genes. So they're, in the environment in which they live, it influences them to be, manufacturing GABA or manufacturing glutamate or having a long axon or short axon. So there we know there's a different gene expression. I've never heard anyone, I'm no expert in muscle.
Well, I think Tom, when you hit the nail on the head there, I mean, they're disease, but think about diseases like Lou Gehrig's disease. Why does it spare certain motor neurons and like the cranial nuclei that's innervate
3,
the
4, and 6.
Innervate the extraocular muscles own its nucleus.
Exactly.
So why is that? Why are those neurons so resistant to whatever is causing degeneration?
Well, at least we know that those neurons might be different because it's a typical thing for neurons. Now, what I'm driving at is I don't know even a single case of someone looking at the expression pattern of one muscle versus another and showing dramatic differences.
There we go. There's something something for young.
We need some biopsies. We need some.
That's a project for next spell.
Well, so, in some of these dystrophies, though, had you biopsied, say, a forearm muscle where it didn't show prominent clinical weakness, would that be abnormal also?
Where there was no weakness, it would probably be a lot less abnormal than abnormal.
Okay. There's a good chance that these are patchy
Yeah, I mean, obviously you wouldn't target that for biopsy, but I suppose that's been done at some point.
This comes up all the time with muscle biopsies that miss their target. You just let me pull it up. If sampling bias, or you don't target the muscle that's appropriately affected, you're going to get results that are going to be erroneous because the muscle will be more. That's true about any muscle.
The same goes for EMG, right?
EMG is the same thing. So
You missed things with EMG.
EMG though is EMG is a little easy because you can do multiple muscles. You can't biopsy multiple muscles at the same time.
I just want to add a last point to genetic testing versus muscle biopsy. I think that I agree that probably for a chronic muscle disease, probably would start out with genetic testing just because it's so non-invasive. And so probably muscle biopsies and nerve biopsies are more really looking for inflammation. So if you have a concern for inflammation, you probably want to do the biopsy first. If it's more genetic, I think that genetic testing would be much less invasive.
I agree with that because for inflammatory myopathy, you're going to commit a patient to a course of treatment with potentially toxic agents. If you're not sure you have the right diagnosis, if you haven't biopsied, then the way to make that diagnosis is to biopsy the muscle. I think that's a mistake, and I see that sometimes, to be honest, from rheumatologists who they just don't do the biopsy, they just automatically put the patients on steroids. But then it really muddies the water because if you can't even, if you do the biopsy, it's already influenced the results, and you may not come to any firm conclusion you can do the biopsy. If the patient's not responding, is that because they're not getting the appropriate immunosuppression or they don't have an inflammatory myopathy? That's a challenge. So I favor doing biopsy for inflammatory myopathy before treating.
And I think that by the history, since it was so chronic, you would think more that this was a inherited disease, and so probably doing a genetic testing would be much better as personal. And the second point I just wanted to add is that Iowa has done a really good job of looking at patients with limb-girdle muscular dystrophy 2I. They looked at whether steroids really changed things in like greater than like 20 patients, and it's all like just a collection of cases. But it doesn't seem like in a larger cohort that really makes a big difference in terms of they're looking at walking as well as pulmonary function. So for my patient, I don't think we recommend. This is not my patient, but the patient that I had that has 2I, I don't think we recommended steroids. Did you guys recommend steroids?
No, we did not. This patient had been lost to follow-up essentially for a few years in between initially being found with his biopsy and then getting the genetic testing and stuff. So we did not have any acute treatments.
I don't want to be the genetic party pooper here. I ordered lots of genetic tests, as several people in the audience obviously know, but I think one still needs to be cognizant of the cost and the fact that many insurance companies are not going to cover these genetic tests. At least in children's, we have a very robust pre-screening policy where pre-authorization has to take place before we actually send the genetic test, so the parents aren't stuck with a $5,000 bill that insurance is not going to cover. Unfortunately, children's can cover some of the cost in certain circumstances, and we still get this done. I don't know what it's like on the results side. Granted, you've got the free limb-girdle panel for Emory, which takes anywhere from 4 to 9 months depending upon you've got secret handshakes to get it done. But I just want to remind people about the cost of these studies and being mindful of working with the insurance company before just pulling the trigger and sticking with the patient or family with a big bill. But I agree, it's cheaper than muscle biopsy. Sometimes.
So it seems terrible to end on the note of
Dr. That's
insurance
one
companies.
I looked up about the differential expression profiling in the muscle, and so the people who care about this are the people who want to eat the muscle. So it's been done in turkeys and sheep. So it's just probably a matter of it's pretty done, and there are differences.
What differences?
I don't know. We'll have to.
I'm going to wait a little bit till it's done over here.
Find the difference between the soft, white, exudative turkey meat and the brown turkey meat, and they marinated it, and they looked which one would take up the marinade faster, and then they
Excellent.
the differential profile
Excellent.
according to that. So
Somebody just wants to eat children.
exactly.
There's a neuromuscular clinic here at UW. Doctor just died.
So Matt, how did he accept, the diagnosis and, because I mean, obviously it's great that, he was diagnosed from our perspective, but.
So Dr. Immunohistochemistry asks, how did he respond to getting this diagnosis? He very much suspected that there was something like this going on, so he wasn't very surprised. He was happy to have a name for it. He had kind of, when I saw him, a lot of other issues going on that kind of kept him from doing that. He had a lot of social issues with his wife actually having had committed suicide, and a lot of depression and anxiety and stuff going on too. So he was having a lot of difficulty with that, among other things. Well, that was initially when he saw him, and then he came back later.
Maybe harbor view as questions.
Let's see. Go to their friendly neighborhood geneticist.
Well, let's thank Matt for a great presentation and Dr. Moss.
Thank you.